So we'll start off with the main lecture topic for today. It's the healthcare quality leadership. Here we are going to discuss the different organizational leadership styles, strategic planning, quality management in our healthcare systems. Okay. If if someone wants to take a break for about 2-3 minutes, now is the time because the session may take somewhere around 1.5 hours more. So kindly take a break. I'll be back within 2 minutes. So welcome back. So let's start at the foundation as to how organizations are designed and why this design matters for our quality. Okay. So I know you all work in a hospital and like you have experienced this also. Some decisions take forever because they may require approvals and sign-offs from 5 to 6 layers of management, whereas other decisions actually happen instantly because frontline staff have the authority. What's the difference? It's the organizational design that is the difference. Okay, organization design actually um, either delays the decision or empowers the frontline staff. So, what's the purpose of organizational design? This is really about making sure a hospital or any organization per se runs without confusion. Okay, it has four classic purposes. Work division. It's like dividing total work into logical functioning groups. I mean, like you break the total work into smaller chunks. Okay, and for example, in hospital we have OPD, IPD, infection control department, OT, pharmacy, billing, etc. Right? So that's work division. Next is task assignment. Assigning specific tasks and responsibilities to each job. So here you decide exactly who does what within those earlier divided departments. Like one nurse actually monitors vitals, another handles medication administration, etc. Right? Now, another purpose is coordination. Here, coordination allowing better coordination of very diverse or complicated organization tasks is also one of the purposes of organizational design. Here you make sure that all different pieces are actually work together, right? In a way, like ER informs ICU regarding the shifting of a patient, and the lab people prioritize the samples from emergency department. Okay, and quality team tracks any delays in the processes. All this is regarding the coordination. And the last is relationships. Here, establishing relationships among these all these individuals, units, and functions. Here, defining authority and communication lines is also one of the purposes of organizational design. Like, what's the relationship? A staff nurse reports to the supervisor, nursing supervisor. She herself reports to the nursing superintendent. In such way, it's a sort of vertical reporting relationship. Whereas quality department and other clinical departments, though they are not above each other, but they work together. So that's a sort of relationship that is defined by the organizational design. Like, in simple words, what in a way, like, it answers three simple questions, like who does what, or who reports to whom, or who collaborates with whom. Okay, so in case if your organization doesn't answer these questions clearly, your quality is going to suffer, because in such organization no one knows who owns the problems, right? Like, if say if there's an incident reported, no one owns the investigation. Or if the target in the KPI drops, everyone assumes that someone is going to handle it and will leave it off as it is. Policy is present, but no one is enforcing it. There are delays because every department works in its own style. There is no coordination, right? I mean, like, for your understanding, let's take one example. Like, if there's a medication error per se, if who investigates is not clear, there will be delay in that investigation. If who implements corrective action is also not clear, there's a high chance that the medication error will recur. If who monitor compliance is also not clear, there is not going to be any improvement. So remember this: poor organizational design directly leads to poor patient safety outcomes. That's the reason why we as CPHQ candidates are supposed to know the basics of organizational design. Now, there are two types of organizational designs. One is vertical and another is horizontal. Okay, so here in this picture, you are seeing a vertical hierarchical model. Okay, so it's a classic pyramid structure: top managers, middle managers, frontline managers, and operational managers. What do top managers do? They set strategy. Middle managers translate that into operations, and then frontline managers supervise day-to-day work. Okay, and finally, operations personnel do the hands-on task. Okay, so in hospitals, this give clear reporting lines and also accountability. But there's a risk. It can also slow down decisions because the approvals must come from up. Okay, and then move down the chain. The biggest strength of this particular model is accountability. There is accountability. Everyone knows who reports to whom, so the ownership is easier to track and escalation path is very clear. But there will be delays. That is one of the negative factors as far as the vertical organizational design is concerned. In a way, like, remember, for vertical, this is a pictorial representation of the vertical organizational design. Here you see many layers of leaders present from top to bottom. And in these structures, the decision, remember this particular thing, decisions flow from top to bottom and information flows from bottom to top. Okay. Now, when you compare that to horizontal organizational design, this, or it's also called as flat organizational structure. Here you see there are somewhere there's an owner, three managers and 6 employees reporting directly to those managers. There are very few or minimal mid-level managers or layers in between. So here, departments report directly to the leader, and here, most of the times, what happens in horizontal organization design is the decision making is most of the times decentralized. Okay, when we compare horizontal and vertical organizational designs, as far as hierarchy is concerned, for horizontal, there are few or no middle layers, but multiple middle layers in vertical style. Coming to decision making is most of the times decentralized in horizontal style and is always centralized and is with the top management from top to bottom. The decisions moving from top down. Okay, in vertical structure. Horizontal horizontal structures are highly adaptive and highly flexible, whereas vertical are low have low flexibility and are in a way like more rigid. When it comes to innovation, horizontal structures encourage them, and there will be fewer barriers also. But whereas in vertical organization, what happens is innovation is less prevalent because there is bureaucracy, bureaucratic hurdles are there, red taping is always there. Okay. As far as speed is concerned, speed of decision making is concerned, faster decision making is done in horizontal because there are fewer approvals, slower when compared in vertical structures. And suitability of horizontal structures is, horizontal structures are often favored by the startups and companies in dynamic industries, but vertical is preferred by established companies in stable industries. Now, if you ask me which one is better or which one is better for quality improvement, there is no one thing for that. It always depends. It depends. If you are like running a rapid PDSA in a small clinic, horizontal structure is better. If you are standardizing some sort of protocols, such safety protocols across a group of hospitals in a healthcare system, there you might need a hierarchy to actually enforce compliance. So the vertical structure may be important. Okay. So the key thing for you to remember is this particular structure shapes culture. Okay, so a flat or horizontal organization can empower frontline teams, but without clear accountability. So the risk of stalling of initiatives is there. In vertical, they can enforce standards, but without empowerment, staff won't report problems. There is also risk in this one. So there's no clear cut best out of these two. It depends on the situation at times. Okay. All right, now let's talk about leadership in quality in a practical way. So, like you all might have tried to improve some process, whether it be hands-off communication or infection control or medication safety. In any sort of improvement process, you already know this truth that the method and approach matters. So, tool matters, but leadership is what makes that particular method stick. Leadership is foundational for the success of QI. Okay, first we'll see the important roles that the leadership plays in making sure that healthcare quality initiatives are successful. See, effective leaders, they don't just tell others what to do. Remember this, they actively lead and help make the change. Okay, so they provide guidance and direction across the organization, right? First, we have support. So, one of the main responsibilities of leaders is to support the organization's commitment to quality. This means visibly backing the quality improvement initiatives, creating the culture of quality where quality is a top priority, and providing resources and support that is needed for the QI efforts, right? So when leaders openly support quality, it actually sends a strong message throughout the organization. Okay, it inspires the team, it encourages them, and definitely consistency. This consistency motivates the staff. Okay, next comes Participation. So leaders must be involved in strategic planning, right, for quality initiatives. Their involvement makes sure that quality is not just on paper, it's part of organization's overall strategy, right? We all know, we learned in the last session that strategic planning means setting goals, or in a way like figuring out how to reach them and monitoring the progress continuously, right? So when leaders actively participate, it shows that quality is priority at the highest levels. And when the leaders participate in QI initiatives, definitely the organization moves along with them. Right? Now, coming to the third one, align. So, alignment is crucial because leaders are responsible for aligning quality activities with the organization's strategic goals. So, in a way, like this means QI efforts are not happening separately, but very much in sync with where the organization is heading. Okay, so all quality activities, whether related to patient safety, clinical standards, or customer satisfaction, should directly contribute to achieving the organization's vision. Remember that. And then finally, engagement. So engagement means involving stakeholders, including staff, patients, and even the external partners like accreditation agencies or regulatory authorities in quality improvement. Okay, so leaders need to create an environment where everyone feels encouraged to speak up, provide feedback, help solve the problems, right? In a way, like I'll be asking what's not on the list. Writing more policies or attending more meetings is not in this particular list of what organizational leadership should do as far as quality is concerned. They should walk the talk, they should support, participate, align, and also engage. Okay. Now, no two people are the same, right? So are the styles. But in broad sense, there are different types of leaderships like autocratic, transformational leadership, transactional leadership, participatory, diplomatic or consultative, democratic, laissez-faire, etc. So there may be a good leader or a bad leader. But when it comes to the style of leadership, there's no good leadership style or bad leadership style. It depends on situations because every style that is listed here has both pros and cons. And you know, the best leaders are situational. They adapt their style to the context, to the team's maturity, and urgency of the problem. Okay. So remember, you'll have to understand these leadership styles because in exam you may come across some scenario and it may be asking as to which leadership style suits the scenario best, or they may give a sort of description of the leadership style and ask us to identify what sort of leadership style is it. Okay, and most of the times that's between laissez-faire, participatory, and autocratic. Most of the times, okay, there's no guarantee, but most of the times. Coming first, we'll look into autocratic leadership. Look, we all know this. This is one of the most traditional leadership styles, an old one, where the leader takes full control and makes decisions without asking for input from the team. Okay, so here the leader is the one who calls all the shots. They make their decisions on their own and then announce them to the group. Like there isn't a discussion at all. There is no brainstorming session. The leader has full authority and their word is final. That's called autocratic or authoritative style of leadership. Okay. This is helpful when we need to take quick decisions. Okay, especially in emergency situations when there is no time to gather everyone's opinion. This leadership style is the best. Okay, they are heavily focused on enforcing the rules. Here, in this style, rules are strictly enforced. Okay, within the organization, there is very little room for flexibility. Everyone expected to follow what the leader has set. Okay, so there is no negotiation at all. You are supposed to follow what the leader has told. Okay, um, this is a sort of military style of leadership. Understand? Here, autocratic leadership is effective in immediate crisis situations. Okay, where or when strict control is absolutely necessary. It's very important uh, that it doesn't work well for every scenario. Okay, it can lead to low morale if used at all the times. We know, I mean, like when I'm talking about authoritative or autocratic leadership, most of us are imagining someone who we know who's a sort of autocratic in his style. I mean, like I can understand because most of the times we see people taking up the autocratic leadership style that brings down the morale of the staff. Okay, so it's not wise to carry this style of leadership every time, but there will be situations wherein this is the best. Like for example, imagine a code blue situation. Okay, there the team lead doesn't ask for votes or he doesn't ask for opinions. He'll just give clear direct commands saying, okay, you do chest compressions, Aisha, you prepare the defibrillator, or he'll say, Mike, you load up adrenaline, right? So in a way, like this is how the autocratic leadership helps in times of emergencies, in times of crisis. There is no time for that code blue leader to take in opinions, right? It's a life and death situation. Patient safety is important, and in such situation, autocratic leadership saves life over that. Okay, now if you lead every meeting like a code blue situation, like barking orders or tolerating no input, definitely your team will get burnout. They will stop speaking up. And if they stop speaking up, what happens? You as a leader will miss out on critical safety signals. Okay. No feedback is provided. So remember, use autocratic leadership style sparingly and strategically. Right? Now, transformational leadership. I mean, like a transformational leader doesn't just manage the day to day things. They craft a strategy to take a department or team to next level of performance and success. Here it's not talking about the status quo. It's not talking about some small improvements. It's talking about the next level of performance and success. Okay. Here the leader is someone who has a clear vision for future. They know where they want to take their team to. They know how to craft the strategies to get there. This vision is not about managing daily operations. It's about pushing the organization or department or team to the next level. Okay. It's like, where do we want to be in 5 years? How can we get there together? That's a kind of long term thinking. That's hallmark of the transformational leaders. Okay. So they know it's not about the goal, it's about people. They focus on motivating and collaborating. Okay. So that's one big plus. They understand that a strong, motivated team is very much a key to achieve the big vision. So we come across this transformational leadership style in some great leaders who have had an immense success in achieving their visions. Okay, so here in this, having a vision and then team building, having that goal set wherein everyone understands those particular things are the hallmarks of a transformational leadership. In hospital context, let me say for example, if a hospital is having a terrible hand hygiene compliance around somewhere around 30 to 40%, and if the chief medical officer just sends another email reminding everyone to wash their hands, do you really think there will be a transformation in that particular culture? No. But instead of sending a simple email or an order, if he launches a campaign, something like clean hands, save lives, let's reach 90% of compliance, and then he invites all the frontline staff to design what exactly is needed to be done. Then he creates the responsible persons. He'll have all the posters put up near the sinks to as a reminders, as a sort of visual cues. Okay, and once he shows that he's tracking it daily with a dashboard with unit by unit performance, definitely within 6 months the unit or the organization may be hitting the target, right? So from terrible 30 to 40% to 90% within 6 months, there was a vision. He set out how to achieve that. He has collaborated with all the responsible staff, right? That's transformational leadership. Vision plus collaboration plus goals. that results into breakthrough results. Okay. Now we come to transactional leadership. So transactional leadership is grounded in daily operations like arranging meetings. It's a sort of keeping the machine moving. Okay, it often includes mentorship and instruction and training also. So it's about maintaining the system every day. But this style sometimes get bad reputation. Like people say, "Oh, that's not transactional leadership is just managing things, and it's not a sort of true leadership or something." But let me tell you, our hospitals or healthcare institutions can't run on a vision alone. Definitely, we need someone who makes sure that the things are done. We definitely need someone who makes sure that crash cart is always stocked. We want someone to actually have the hand hygiene audits done on schedule. We need someone to train the staff, right? So, transactional leadership is a reliability engine of quality for us. But remember, if we only lead transactionally, quality becomes a compliance activity. It will never be a quality culture or having a shared mission. Okay, so in a way, like this isn't a question of which style is best. It's about what the situation requires. If it requires for you to motivate the staff, do it. If it requires for you to stand there, do it. If it requires for you to coach the people, train the people, then do it. A sort of transactional leadership. Okay. Now, coming to the participatory style. Look, this is one leadership style that brings everyone into the decision making process. Here, the style focuses on collaboration and also on hearing everyone's voice. Okay. So, here, the leader doesn't make decisions alone, they present the decisions or ideas to staff or the team members and ask for their suggestions. Once the input is received, the leader will make the final decision. This is a big difference between participatory leadership as well as democratic leadership. Remember this. Here, the idea is presented, it is discussed, inputs are taken, but the final decision is with the leader itself. Okay. And also, one important thing is he will allow everyone to contribute. Okay. He'll treat every employee with consideration and respect. It's not just about listening to them, but it's also how much you are valuing the employees or the team members for them to say, for them to give that feedback. Okay. So naturally, when people feel like their ideas are important, they're more likely to be engaged and motivated. Right. So remember, employee involvement is key here. It's about creating an atmosphere where everyone feels they can speak up and be heard. Right. And another thing is, it's more about building consensus. So building consensus means what? It doesn't necessarily mean that everyone agrees 100% regarding that idea that was presented by the leader or the idea that was discussed, but eventually everyone supports the decision and are willing to work for it, right? So here the leader aims for a broader support, even if it's not unanimous. I hope you all understand this particular nuance, right? So, this participatory leadership style helps create unity and team spirit. Here, your team members feel like they are more connected to the decision because they were involved in discussions regarding that particular idea, regarding the process, and they have this sense of ownership. Okay, so in a way, like I have this question for you. Like, you see, you as a staff or a leader, just try to think about this. If the team disagrees with a change, do you think they disagree with the idea or they disagree with the way it was communicated to them? The most obvious answer is the way it was communicated to them. Idea itself might have been good, but if at all that's communicated well, with respect, with consideration, with proper involvement, then they would have agreed it properly, right? So here's where participatory leadership reduces the problem because people are are involved in this. They shape the solution. And I personally call this is the best style for a sustainable change because it builds ownership. Once the ownership is built, then enforcement happens automatically. Okay. Now, coming to diplomatic or consultative leadership. Here, this is all about getting people on board through persuasion and communication rather than by giving orders. Here, the leader sells the decision to the team, diplomatic or consultative leadership. In a way, like here, the leader behaves like a salesman. Okay, they present a decision as something that will benefit the whole team, explain the reason behind it, and he shows how it aligns with the team's goal. Okay, in a way, like this helps create the sort of buy-in from the team. When people understand the reasoning behind the decision, they obviously some most of the times they support the decision and will make best effort to make it I mean, like make it a success, right? So it is one of the most effective thing in redesigning quality improvement processes, especially during mergers. So you may come across a situation wherein a scenario may be given for you regarding mergers and all. They might be asking as to which leadership style is better. So remember that diplomatic or consultative leadership is better in such situations because, for example, let's say two hospitals are merging. Okay, two different EMRs, different protocols, different cultures, and anxiety will be high in both the employees because during mergers people are naturally anxious because they may be coming across new workflows, new reporting lines, new culture, etc. So the anxiety will be there. In this situation, a consultative leader doesn't pretend that the decision is open for debate. He's not taking into consideration that okay, if you're feeling bad, we may not go ahead with merger or something like that. Here merger is decided, merger is going ahead definitely. People doesn't like to be merged, but here the leader explains the rationale. He acknowledges the concern of the staff, he listens to their feedback, adjusts implementation where possible, and in doing all this he's selling the change. He's not dictating it. He's not dictating it like a authoritative leadership, like okay, you're supposed to do this, that's it, there's no other way or something like that. He's not debating about it also. Here he's guiding people through this particular difficult through this merger or through this quality improvement process with respect and transparency. Okay. Now coming to democratic leadership. So in a way, like this most of you know, here the leader presents the problem, asks the team to come at solutions, and usually makes the final decision based on team input. Most of the times it's the agreement of majority. Here the agreement of majority is the key for democratic leadership. Okay, so but there's a catch to it. It is most effective when working with effective and self-directed work groups only. If they are experts only, they can come up with better solutions and majority can be agreed upon, and that may lead to better sort of results. But in case if it's not the case, let's say they are not experts, they are not self-directed, they have come up with one solution which may actually be bad to the system, but the democratic leadership has to accept it because that's their style. And if they adopt that bad sort of idea, then everything goes down, right? So remember this, this works effective with self-directed people. Like for example, if I say if your ICU team has 10 years of experience and you want a redesign of your daily round process, because as a democratic leader, I mean, like in such situation, this democratic leadership works because you say, here's a problem we have. Our daily rounds are taking 90 minutes, and in a way, like we need to fix this. For such situation, your ICU team with 10 years of experience will definitely work because the team may brainstorm, they come up with votes, they will refine the process. And finally, you as a leader, democratic leader, will approve the winning solution, okay, majority. But if the team is new or the problem is urgent, this democracy can slow you down or lead to sort of unintended outcomes. Okay, so the context does really matter. That's what you should be remembering. Now, coming to laissez faire leadership. Here, laissez faire in French means let them do. It's a sort of lazy leadership also. right? So this leadership style is quite different from what we have discussed so far. It's about giving your team the complete freedom to make their own decisions. There will be minimal interference from the leader. Okay, so here the leader takes a step back and lets the team members take the most of the decisions independently. There is very little guidance or control from the leader. In a way, like he'll provide the resources if needed, but then they don't interfere much in the day-to-day decisions of the team. It's a sort of empowering the team members who are capable and confident. In a way, like this is giving a lot of autonomy, right? It works best only with the team if it is highly self-motivated, right? And experts who don't need constant direction or supervision. Every one of us might be feeling like, okay, we want such a boss, but most of the times what happens is there's a down I mean, like this will be a challenge. This sort of leadership will be a challenge and may lead to low productivity at times, most of the times, because without guidance some team members may struggle to stay focused or motivated. Okay, so remember, in quality improvement, like it's like, sure, go improve hand hygiene, let me know how it goes. If you do that, do you really feel something will happen? No, nothing happens, because the barriers were not removed, time wasn't allocated, no one followed up, hence the failure of QA project. Okay, so remember, use this style only when you have high capability, high trust team with clear authority to act, right? Now, coming to situational leadership model. Okay, so this is a sort of situational leadership model which you are seeing now. So this model will help us understand that no one size fits all approach as far as leadership is concerned. Instead, the most effective leaders know how to adapt their style to meet the needs of their team members and challenges they face. Okay, so here you see there are four different leadership styles in this particular model. It maps the directive behavior from low to high across the bottom and on x-axis, and supportive behavior from low to high up on the side on the y-axis. And directive behavior on the x-axis, supportive behavior on the y-axis, and it shows four zones. S1, that is directing, high directive, low supportive. Like here we say, like, do this and here's how you are supposed to do this. S2 is coaching, like high directive, high supportive. Here we say, here's how you're supposed to do, and I'm here to help you, right? S3 is supporting, low directive, high supportive. Here we say, like, you know what to do, and also I'm here if you need me. And S4 is delegating, low directive, low supportive. Here you say, like, you know this, you've got this, go and do. That's it, right? To elaborate, the first is directing, like it gives clear instruction and closely supervise their team members. And this approach is useful when the team is new or they lack skills required for that particular task. They need everything from you, right? So you are supposed to direct them and handhold them. As far as S2 is concerned, coaching involves both high direction and high support. Here, the leader still provides clear instructions, but also works to encourage and motivate the team. This style is effective when team has some skill. They have developed some skill, but still they need guidance and boost in confidence. Okay. S3 is supporting. Like it's about high support and low direction. Here in this, what happens is the team is more capable. They doesn't need much direct supervision. Here, the leader's role is support and encourage, allowing the team members to take more responsibility in making the decisions. S4 is delegating, like when the leader completely steps back, offering low direction, low support, and gives full autonomy to the team. Okay, in a way, like if at all we take a practical example, if you say, like, if someone is new to incident reporting, you might start in S1. You will explain them the clear steps, clear expectations are given, tight coaching is given. Okay, as they build confidence, you move to S2 and S3, still present but in a way like increasingly empowering slowly. And for an experienced staff member who leads PDSA cycles and QA initiatives, then you can come to S4. You can delegate the outcomes, you trust their method and say, okay, you go, do, I'll be watching. Okay. So this is a situational leadership model. Now, what makes a leader truly successful? Here we see the list of traits that make the leaders credible and help him to be successful. Vision means you can describe the future in a way that makes people want to go there. Okay. And integrity means your team trusts you will do the right thing even when it's inconvenient. So, honesty and ethical behavior are crucial for leadership success. Communication means you translate quality strategy into what people do on their workplace. Like they must communicate clearly and inspire others, right? So, modeling behavior means you should act like a standard, like if you say hand hygiene, respectful communication, speaking up, because all these things, because staff watch what leaders do more than what you say. They will watch you. You should demonstrate the behavior that you are expecting from others, right? And then, for example, if we say, like, if we enforce a safety rule, uh, only after something goes wrong, we are teaching people that safety is optional until it's public. And in a way, sometimes, if we are supposed to take bluntly, if you say as a leader that hand hygiene is mandatory and then you walk past a sink without washing your hand, your team will notice it. That's some sort of modeling behavior. Okay. So they'll conclude that safety is optional, it's not public. That's why modeling behavior is most powerful tool you have, because your team watches what you do, not what you say. Okay. And accountability, leaders should take responsibility for their actions and decisions. And consistency, actions consistently align with stated values and goals. Okay. Now, comparing leadership and management, here it's highlighting the distinct roles within an organization, right? Leadership is about producing change and movement, and management is about creating order and consistency. Remember, both are crucial for organization success, but they involve different activities and skill sets. Now let's go through. For leadership, it establishes the direction. It is focused on creating a vision, clarifying big picture, setting strategies that inspire change and movement. Okay, it aligns people with good communication. Here, leaders communicate goals, they seek commitment, build teams, coalition, alliances, and leaders energize their team, empower colleagues, and strive to satisfy the needs, right? Whereas management establishes agenda, sets timetables, and allocates resources to ensure operations run smoothly. And they provide structure, make job placement, establish rules and procedures to maintain consistency. And also, they develop incentives, they come out with creative solutions, take corrective actions, and all. Leadership is about change, vision, and inspiration. It's about setting a direction and also motivating people to move forward. Whereas management, on the other hand, is about order, structure, and consistency. It's about ensuring that everything runs smooth and that the team stays on course. Like, for you to understand, a leader is a sort of, what do you say, the top level sort of top level boss. Management is the middle level boss who actually enforces the leader's vision. Okay. For a successful organization, we need both leadership and management. Now, we shift from who leads to how leaders think. That is systems thinking in healthcare. See, it has four layers: events, patterns, system structure, and mental models. What's an event? An event is a single incident. For example, let's say a medication error. Let's take the example of medication error. Okay. So, an event is a single incident of a medication error. What's a pattern? It is what you notice over time. Maybe similar near misses every week on night shift or on a particular day or in a particular shift. Okay. Then system structure. It is a deeper design like policies, staffing models, procurement delays, etc. And mental models are beliefs people carry, like, okay, pharmacists will catch it anyway, or speaking up may cause me trouble. These are the beliefs and assumptions, the culture, right? So here, this matters because quality leadership isn't just reacting to events, right? It's reshaping the structures and mental models so that fewer events happen in the first place, right? In a way, like, what do you say? This aligns with how actually major safety organizations talk about safety culture, right? In a way, like, let me ask you a question. When a medication error happens, do you investigate the event, or do you redesign the structure and challenge the mental model? Because I know you are going to fix the process, you are going to redesign the structure and challenge the mental model, because systems thinking says don't just fix the event, fix the system, right? That's the system thinking. Events are the ones which are visible for us, a sort of tip of the iceberg, but the bulk of the iceberg is below the sea level. Okay. Coming to root cause analysis, RCA, it has 4 steps: problem identification, data collection, cause identification, solution development. Problem identification means we define the issue clearly. What happened? Whenever an event happened, we whenever an incident is reported, we do root cause analysis, right? So here the problem identification means we define the issue clearly, like what happened, to whom it happened, when it happened, what sort of harm or risk that has resulted, right? Next step is data collection. Here we gather facts. Remember, we gather facts, we do not gather opinions. We see the timeline, we interview people, we look into policies, environment, and what's happening in the system that day, right? Next comes cause identification. Here it means we generally don't stop at the human error. We keep asking why, 5 whys, why, until we can reach to a point that suggests the system vulnerabilities. And finally, solution development. This is where actually leadership matters the most. Teams can do brilliant analysis, and then leadership either funds the fix they are proposing, or simply they can file the report and put it aside. I have seen many RCAs that end up with re-educate the staff as a final sort of recommendation. That's not the solution. That's a cop out. Strong solutions look like what? Standardization, or implementing new forcing functions, removing redundancies, creating better system designs, easier workflows. But all these require leadership commitment and resources. Okay. In a way, like organizations like IHI and Joint Commission have recently moved towards RCA square, RCAA, that is root cause analysis and action, which actually emphasizes on stronger action at system level, not just the individual retraining. The focus is on interventions that genuinely reduce the recurrence of those events. Okay. Now we are going to talk about ambulatory care quality management. See, and also the problems associated with quality management of OP care. Here, um we come across scattered care. This is a problem. Scattered care is a problem. Okay, there is no common medical record in the ambulatory care setting. Underdeveloped record management in OP setting, and greater patient control over diet and adherence, plus issues like wrong access to specialty care. Imagine a patient with diabetes who goes to a small private clinic to see his family doctor. He also goes to a public hospital for his endocrinologist consultation, and also visits a local pharmacy for his medicines. In all this sort of cycle, there is only partial information available to the providers, right? So that's scattered care. There is no uniformity. There is no sort of concentrated care. There is no record available of that particular patient with all three of them. It's a quality risk because no one will see the whole picture. And patient control is a double-edged sword. It's empowering for the patient. Here, the patients live outside our walls, but it also means outcomes depend on the patients. The patient may not adhere to his medications. The patient may have certain dietary preferences. The patient may not be good at health literacy. Okay. So, all these things do pose a challenge for us. So, in a way, like ambulatory quality often builds on like often relies on building bridges between all these things: better documentation, better transitions, shared decision making, and better access pathways and all. That's always a challenge as far as ambulatory or OP care setting is concerned. Now coming to managed care organization or MCOs. What is an MCO? Okay, so in a way, like MCOs are responsible for both delivery and financing of healthcare services. I mean, like that means they not only provide access to care through their network of doctors, but also they handle financial aspects. I mean, like think of MCO as a one-stop solution, one-stop shop for both paying and accessing healthcare. Remember, these are often run by insurance companies, okay, and play important role in managing healthcare costs. One of the main function of a managed care organization is to establish link between providers like doctors and hospitals, patients, those who need care, and payers, usually insurance companies or the employer who cover the cost for the treatment. Okay, this connection between provider, patient, and payers is very much essential so that everyone gets involved and are on same page regarding the cost and quality of care is concerned. Okay, so here in this MCO model, both patient and provider have agreement with the MCO. Patient agrees to pay for the services here usually in form of insurance premiums or co-payments. Okay, and provider agrees to deliver the services at pre-negotiated rate. Okay, so the main goal of managed care organization is to control healthcare costs while ensuring there is a good quality care. Okay, so here by managing both financing and the delivery of care, MCOs can create efficiencies and reduce unnecessary expenses. For example, MCOs often focus on preventive care like regular checkups, vaccination, etc., in order to avoid costly medications or costly medical procedures later on. Right? So in a way they do have utilization review process also, and also they negotiate lower rates with with the providers. Overall, this helps reduce the cost of the treatment. Okay, now coming to health maintenance organizations, or HMO. In a way, like HMO is a sort of network that provides insurance coverage for a fee, right? So here they aim to provide comprehensive healthcare services in cost effective way. So what they do, they establish a network of doctors, hospitals who are under contract with an HMO. Like when you join an HMO, you are agreeing to use the healthcare provider that the HMO has partnered with. I mean, like you as a patient will pay something to the healthcare maintenance or HMOs, usually some sort of monthly premium or something like that, and agree to take treatment from the network provider. Means the doctors and hospitals who have the contract with this particular HMO within their network. You can't go out of this particular network, right? So this is a defining feature of HMO. The members are often required to choose their primary care physician. Okay, this primary care physician acts as a main point of contact for all the healthcare needs of this patient. Okay, of this person, and he is responsible for routine care, and also he will be coordinating any specialist referrals if needed. Okay, this particular gatekeeping function of you going to a particular primary care physician for all healthcare needs actually help the HMOs manage the cost. Okay, by providing appropriate care and also avoid unnecessary services. Okay, this particular HMO model has both advantages and disadvantages. On plus side, because this HMO has control over where you get your care, they can ensure the services are provided efficiently and cost effectively. But on the downside, what happens? The choice of providers is restricted. You can't take treatment from the doctors or the providers outside this particular network unless it's an emergency. Okay. So this is one of the downsides as far as health maintenance organization is concerned. Now let's talk about different reimbursement types. The first is prospective payment service or PPS. Okay. What happens in PPS? Here, the healthcare provider receives a predetermined fixed payment for the services they deliver. Means the payment is done in advance. Okay. It is based on type of service that is provided or the diagnosis that is made. There is no link between what the actual cost that might occur for that particular treatment. If the diagnosis is done, depending on that diagnosis or depending on the service that is going to be provided, there is a predetermined fee and that will be paid to the healthcare provider. For example, in an IP setting or a hospital setting, a diagnosis related group might be used to determine a fixed payment amount. For example, let's say for pneumonia, okay, there is some amount, X amount that is being given for a pneumonia patient in a hospital. This fixed amount is paid to the hospital at the time of admission for that patient, no matter for how long the patient stays, okay, or whatever specific treatments they require. The aim of this type of payment is to encourage the efficient use of resources. It's one of the major advantages. It forces the organization to make balanced use of resources. Because the payment is fixed, the hospitals will try to efficiently manage the cost. Okay. And they will discharge the patient as soon as they're medically fit, right? In a way like the hospitals are incentivized to prevent complications and to reduce length of stay. Okay. So there are also some sort of disadvantages because this prospective payment sometimes lead to potential undertreatment also. That's a challenge because sometimes if the healthcare provider tries to limit services to stay within budget, that's a risk to the patient. Okay. That's one of the downsides of prospective payments. Now coming to retrospective payment. Here, unlike PPS, the payment happens to the healthcare provider after the service is being done. Okay, based on actual cost of care. Okay, there are two types. That is fee for service and discounted fee for service. In fee for service, the providers are paid for each individual service they perform. Okay, if a patient has multiple procedures, each one will be billed separately. Okay, and the provider is paid. As far as discounted FFS is fee for service is concerned, here it is similar to fee for service, but the final payment is negotiated at a discounted rate. As simple as that. Okay. Retrospective is a little bit more flexible for providers because they are reimbursed for all services that they provide. But one of the biggest and significant drawback of fee for service approach is it may sometimes lead to overutilization of service. Okay, as far as FFS is concerned, underutilization. As far as retrospective is concerned, overutilization. There was one question that we have discussed it in the last session regarding this. Okay. Now coming to managed care payment methods. So there are two types of managed care payment methods, that is capitation and co-payment. Capitation is like we pay you X amount of dollars per patient per year, whether they need one visit or 20 visits. Means here the main idea is there's a fixed payment per person regardless of services received. Here the organization enters into an agreement with the insurer saying that you pay us monthly X dollars and we will provide services to that particular patient for n number of times of his visit, or even if they don't visit, you are going to charge that much. Okay. By doing this, since the payment is fixed, the providers are encouraged to focus on preventive care. Okay. Even if the patient comes one time or 10 times, he is still going to get the same amount for that particular month. Okay. So for this, what happens is the health provider ensures the patients stay healthy and reduce the number of visits. Okay, so by that way, they will efficiently manage the cost. As far as co-payment is concerned, it's like it's a fixed amount paid by the patient for each service, right? It's like the insurer saying to the patient, like every time you visit, you pay X amount of dollars out of your pocket by having a copay. Okay, by having this copayment, patients are encouraged to think carefully about their use of healthcare services. Here, what happened is there's X hospital getting into agreement with a Y insurance provider. You and I are there. We registered with that insurance provider with that particular hospital for managed care payment method. Okay. Now I pay $100 every month to the insurer and same payment goes to the provider. Okay. Here, what happens is I pay premium and I'll go visit the hospital. But now when I pay 100, irrespective of if I go once or 10 times, I should not abuse the system, right? If the provider charge, if the insurance asks me to pay $10 per every visit, I will make use of that particular visit judiciously. I'll go to the hospital only if required. Okay, I hope you got why this capitation and co-payment methods were introduced. Okay. Now, coming to the difference between complication and comorbidities. Look, this is also one of the questions that we have discussed in the last session. Yeah, it's important for us to know the difference between these two conditions because this definitely influences the patient care and outcomes. Not only that, they represent different scenarios and these also matter for coding, reimbursement, and quality measurement also. So here, complications means these are the conditions that aggravate the original disease, but were not present at the time of admission. Not present at the time of admission. They arise after the patient is already under treatment. Okay. Comorbidity means these are the secondary conditions that are already present at admissions. These conditions coexist with the primary illness and affect the treatment plan or length of stay. Okay. For example, if a patient is admitted for pneumonia and develops a hospital acquired pressure ulcer during his stay, that's a complication because that was not present at the admission. The pressure ulcer was not present at the time of admission, but after the admission, right? During the care process. Whereas if the patient arrives with pneumonia and the diabetes is a comorbidity. Okay. Why does this matter? Why does a complication or difference why should a complication or comorbidity matter? Because many pay for performance programs and public reporting systems penalize the hospitals for complications. They penalize the hospitals for complications, hence forcing the hospitals to care better or to improve their quality, right? But sometimes they do adjust for what do you say? The authorities do adjust for comorbidities. That's not an issue at all. Now, the cost of quality in healthcare. Understanding the cost of quality helps us see as to how much we invest in delivering quality care. And most importantly, how much it costs when we don't. Okay. So the price of non-conformance is also called as cost of poor quality. What does it refer to? It refers to expenses incurred when errors or failures occur in healthcare delivery. I mean, like these are the costs that arise when things don't go as planned, when mistakes happen, where corrective actions are needed. Like, for example, imagine a scenario where a patient receives wrong medication. The resulting cost could include additional medical treatments or extended hospital stay, or worse, some legal expenses also. All of these are considered part of cost of poor quality because they were avoidable. If things were done correctly in the first place, it would have been avoidable, right? So the price of non-conformance is often much higher than we realize because it not only includes the direct cost of correcting that particular mistake, but it also includes indirect costs like damage to the hospital's or the provider's reputation that will lead to patient dissatisfaction also, and sometimes even the loss of trust in the system itself. These are all the indirect costs. Okay. These are all the cost of poor quality. Now coming to the price of conformance or the cost of quality. Okay. It represents cost of executing quality measures and doing things right from the beginning. So these are the investment in a way, like to prevent problems before they happen. For example, is the training healthcare staff on best practices or conducting regular audits and implementing safety protocols. All these are part of the cost of conformance or cost of good quality. Okay. So, or cost of quality per se. So, what's the idea behind the price of conformance? It is that by investing in quality initially and upfront, we prevent errors. We promote best practices. And by doing that, we save costs in the long run. It's like, in a way, like it's like prevention is better than cure, right? So by spending on prevention, we can avoid much higher costs associated with correcting problems later on. If we invest right into the cost of quality, we can avoid higher cost of poor quality later on. As simple as that. Okay. Financial reporting in the context of quality is all about identifying and reporting quality related costs to ensure that organization stays committed to quality improvement. Now, when you calculate the cost of poor quality and calculate the cost of good quality, that gives us a snapshot of how we are going ahead. Okay, in a way like that's regarding the financial reporting is concerned. It's tracking both the cost of good quality and bad quality and using that information to make informed decisions, right? So here's the visual showing the cost of good quality and cost of bad quality. Remember, cost of good quality includes prevention costs and appraisal costs. Okay. And cost of poor quality includes internal failure and external failure things also. Right? Think about where I mean, like now, imagine your own organization. Now think about where your organization is spending its quality money on. In case if you are daily constantly firefighting, like investigating the incidents, if you're compensating patients or running re-education sessions for your staff, you are in a failure quadrant, right? On the right side, the red side. But the leadership move should be towards the left shift. Try to invest more in prevention and appraisal so that failures never happen in the first place, right? Now, coming to the role of quality council, we all know the quality council means it's a steering committee, the apex committee as far as the quality is concerned in an organization. It involves the top leadership along with the department heads and everyone, so that they give a sort of vision towards the quality initiatives is concerned. There are four core quality roles of quality council here. They are supposed to provide the direction and oversight. They should provide organizational direction for QI initiatives. Okay. Then they should help in prioritization. They should identify and prioritization which prioritize with improvement opportunities. What are the QI projects that are supposed to be prioritized first, and then what, and then what, and then what? That's the responsibility of the quality central quality council or apex quality council. Then they are supposed to select the team. They are supposed to select the team which actually does the quality improvements, and then they are supposed to sit down and evaluate. They are supposed to review outcomes and assess the effectiveness of the quality initiatives. Okay, so in a way, like the quality council sets the compass. They are supposed to allocate resources, remove barriers, and they are supposed to hold the QI teams accountable. Okay. Remember this, without a functioning quality council, you can have as many uncoordinated initiatives as possible, but still nothing will be achieved without a functioning quality council. Now, focusing on essential parts of quality improvement is prioritizing quality initiatives. In a way, like we have earlier discussed a question regarding which quality initiative you are supposed to prioritize first, right? So this particular prioritizing quality initiatives, this step is all about choosing the right project to improve patient care and outcomes in the most effective way. So how is it done? Impact assessment is the starting point for prioritizing quality initiatives. This means evaluating how a potential project might impact patient care and health outcome. For instance, a project aimed at reducing medication errors in a high-risk patient population would likely to have a significant impact on safety. And we should focus on this particular thing because of the most substantial positive impact on patient outcome. So once we have identified the high potential impact, we are supposed to provide the sufficient resources. Okay, now when allocating the resources, we are supposed to do a feasibility of each project. Okay, whether sufficient staff is available, funding is available, and what's the time frame and all. It's crucial to determine all these things for a successful implementation of an initiative. Okay, in a way like and the final step is alignment. Here in this all these quality initiatives should be aligned with organization goals and missions. Like for instance, if the organization mission is to be a leader in patient-centered care, we need to prioritize initiatives that promote patient engagement and also which improve the patient experience, right? That's a bigger picture, right? So alignment with organization vision and mission. Now, specifically, we should prioritize initiatives that target high risk, high volume, problem prone, and high cost areas. Let me explain. What is high risk? These are the areas where mistakes can lead to serious harm. For example, surgery and medication management. These are high risk areas that require your constant attention to ensure patient safety, right? These are the high risk areas. Next is high volume. Like these are services that your healthcare organization provides frequently. Like even small improvements in high volume areas can lead to significant gain, right? Then comes problem prone. Like these are the areas where issues are more likely to occur. For example, like between the handovers. Okay, and high costs. Initiatives that can help reduce high costs are also should be prioritized, but in this particular order: high risk, high volume, problem prone, and high cost. Now, what are the three pillars of organizational direction? These are vision, mission, and values. Vision is aspirational view of an organization's future. That is like what do we want to become or where do we want to be in future. That's vision. Mission for an organization is the core purpose and focus of the organization. Like this is what we do to reach the vision, right? And values are the guiding principles that shape the organizational culture. In a way, like I once visited a hospital where the vision was displayed in the lobby, in the entrance, to be the safest hospital in the region. But when I asked the frontline staff, "What's your vision?" Most of them shrugged off because that vision is not what do you say spread throughout the organization. It is just for the display. Remember, a vision here in this case wasn't real. Okay, it's not repeated, it's not owned, it's not lived by those staff. A vision should be specific, a mission should be action oriented, and values should be simple and measurable. Okay, so this is what we have talked about. This is one example of a vision, mission, values of an organization, Mefik Capital in Saudi Arabia, wherein their vision is be a leading investment service institution in Saudi Arabia. That's their vision. In future, they want to be the leading service investment service. Okay. Mission is treat our clients as partners and provide high quality, distinctive investment products and services. So this is their way. This is their day-to-day way. They want to treat their clients as partners, provide high-quality, distinctive investment products and services. And by doing this, they want to be the leading investment service in Saudi Arabia. So that's what it is. They want to have this mission in order to achieve the vision. And as far as values are concerned, integrity, professionalism, loyalty, commitment, local knowledge. So notice the clarity here. The vision is specific, leading in Saudi Arabia, not in the world. They want to be in Saudi. There's a clarity in this. The mission is action oriented. treat clients as partners. Okay, and the values are simple and memorable, like 5 words. There is no paragraph or anything, 5 simple words. Okay, this is how you make a vision stick. This is an example of vision, mission, and values. Okay, now coming to strategic planning in healthcare. So it gives us three strategic questions, like what's the current state, what's the future state, and what is the action plan. Okay, so current state assesses what the organization is currently doing. Future state is concerned with what the organization should be doing. Action plan is like to develop strategies for achieving those desired outcomes. Like, you see, the questions for classic strategic planning questions are like, what are we doing? What should we be doing? What should we be doing next? How should we be doing it? And what should we not be doing? The last question, what should we not be doing, is the hardest one because it requires you to stop programs, say no to well meaning ideas, and let go of legacy initiatives that no longer serve your mission. Sometimes letting go is an important thing. What you should not be doing is a tough question, but definitely you are supposed to do that. That's where the strategic discipline comes in. Okay. Now, here are the 5 steps of strategic planning process. In step 1, define the strategic attributes like mission, vision, mission, and core values. And after that, set the strategic priorities. Okay. In a way, like the strategic priorities are the pillars for the future strategy. Okay, how do you do that? You're supposed to have your balanced scorecard. Okay, SWOT analysis, pestle analysis, gap analysis, risk assessment, everything, right? And after that, step 3 is description. Here you describe the business goals. Business goals are building blocks of strategy. Okay, the strategic map, KPIs are quantification of your business goals. Okay, initiatives, leading metrics, everything. And then step 4 is cascading, like translating the strategy across the levels and units. You're supposed to in a way, like you should be communicating that across your unit. And then step 5 is execution, working on those strategic initiatives. Okay, I know that's a lot, but in a way, like if at all, to summarize, let's say step 1 and 2 are about thinking, right? Where are we going? What frameworks will we use? Step 3 is planning. What are the goals? What are the metrics? And what is the initiatives? Step 4 and 5 is doing, cascading, and executing with accountability. Remember, most organizations are great at steps 1 to 3. They write beautiful strategic plans, but error prone areas are 4 and 5. Most of them fail at step 4 and 5 because they don't cascade goals to frontline units. They don't track KPIs weekly. They don't hold people accountable. Strategic planning without execution is just wishful thinking and is fiction. Remember that. Now, here, in a way, like the same thing, the top leader and the governing body are supposed to frame the vision, mission, and values, make SWOT analysis, set the goals, objectives, strategic initiatives and action plans, and then set the strategic plan on the departmental level, give the budget, process review, evaluate day-to-day work. This is how the cascade in action is. Okay. Now, SWOT analysis in healthcare. You all know SWOT analysis: strengths, weakness, opportunities, and threats. Right? In a level like SWOT matrix, one of the most famous strategic tools. Right here, see, strengths are what are your strengths? Weaknesses are what are your weaknesses? What opportunities you have in the market? Strengths and weaknesses are internal. Opportunities and threats are external. Okay. Strengths like we have a dedicated infection prevention team and low hospital acquired infection rates. That's a strength. Weakness is like we have high nursing turnover and no succession plan. That might be a weakness. As far as opportunity is concerned, okay, new value-based payment model rewards quality outcomes for us. And threats is like there's a competing hospital that's being just opened with state of the art thing just beside our hospital. That's a threat. Okay. So in a way, like that's how you're supposed to chart your strength, weakness, opportunities, and threats. And here, how to utilize the SWOT strategy matrix. Use strength and opportunities to exploit external what do you say, strength and opportunities to exploit the external opportunities. Okay. Um like how we discussed earlier, we have a strong infection prevention team and there's a new value based payment model. That's an opportunity, right? By doing that, let's market our low hospital acquired rates to attract more customers. That's the strength and opportunity, right? ST is strength and threat. Here, in the same example, we have strong reputation is the strength. Competitor opened is a threat. But let's emphasize on our patient experience score. By doing this, that's a ST strategy for us. Weakness and opportunity strategy is like we have high turnover of staff, but opportunity is like there's a new nursing school or a nursing college partnership that is available. So that's an opportunity. Then let's build a sort of residency. Let's address what are the reasons for the high turnover of the nursing staff is there and all. Okay. And now coming to WT strategy, weakness and threat. We have high turnover of nurses. There's a new what do you say, there's a threat with labor market. Then we'll sit down, redesign roles to reduce the burnout. Okay, that's how you are supposed to take in the SWOT matrix. Okay, so here it's an example of the same thing. Another example. Remember, I mean, like SWOT analysis is only useful if you're specific. Vague strengths like we have good quality, that means nothing. Specific strengths like loyalty program, like we have 15,000 new members last year. All these things are like actionable ones. They should be specific. Now, right, the same example again. Now coming to pestle analysis. Okay, this is another sort of uh, strategic framework. It complements the SWOT. Okay, but it's helpful to analyze the external environment. Here, pestle means political, economic, social, technological, environmental, and legal. You see, SWOT is mostly internal external balance, and pestle is a sort of macro environment and mostly external itself. P politics means elections, government stability, healthcare policy. What's the external environment regarding this, right? Economic means what about interest rate, inflation, and all. Social, like health consciousness, cultural attitudes, aging population, technology, etc. Okay, when you design a 5-year strategic plan, remember which pestle factors are more relevant to your organization. Okay, by doing that, you will be able to mark and properly plan. Okay, this is how you are supposed to mark your pestle and use a pestle framework and mark your strategic objectives by identifying all these things in the macro environment like political, economic, social, technological, etc. Right? So now coming to the SMART goals. In a way like this, we have discussed in the earlier session as well. The goals, your goals should always be SMART, like specific. Like you should plan effectively with specific targets in mind. Okay. Measurable. They should be measurable. If you can't measure, you can't improve. Okay. Attainable. You should set realistic, attainable goals. You should not be over challenging yourself. Okay. Relevant, that should be relevant to your purpose, to your mission, vision, your strategic objectives, and all, and to that particular context as well. Time bound, there should be a specific deadline. You should be able to monitor the progress and also reevaluate. Okay, so that's your aim. The effective goals and aim should be smart, right? Like, for example, uh, uh, It should be reduce central line infections. It should not be vague like improve safety, right? Measurable like reduce central line infections from 3 per thousand line days to 1 per thousand central line days, right? It should be attainable, like stretch. I mean, like you're not reducing from 3 to 0, you're reducing from 3 to 1. It should be relevant and time bound. By when? When are you supposed to do this? By December 2026. So the smart goal is like reduce central line associated bloodstream infections in ICU from 3 per thousand central line days to 1 per thousand central line days by December 2026. That's a smart goal. Okay. It's specific, measurable, attainable, relevant, and time bound. Now, what are goals and what are objectives? See, a goal is it's a long term outcome and is written as an overall statement. It needs somewhere around 3 to 5 years, and it never answers how we are going to achieve that particular thing. Okay. Whereas objectives are measurable, they are quantitative, and they are explicit. They specify a time for completion, and they also identify the person who is responsible for completion, and they will also answer how you are going to meet that objective. For example, become a high reliable organization. That's a goal, broad. Okay. Whereas objective is like, how do we become high reliable organization? Objective 1, objective 2, objective 3, in that way. Objective 1 rates like reduce serious safety events from 12 per year to 6 per year by December 2026. That's an objective 1. Okay. And for this, owner is the chief quality officer. So this is clear objective. It's measurable. It's specifying the timeline. It's identifying the person who is responsible for it. And it's also telling you how to achieve that. Objective 2, like implement safety hurdles in 100% of the units by June 30th. And owner is the nursing superintendent. So here also it's measurable, time bound, responsible person is given, and it also says how. That's an objective. That's a clear difference between a goal and objective. Okay. Now, this is a sort of dashboard wherein you see KPIs, scorecards, goal meters, and cards. Okay. So, what is strategic versus master planning? Again, master planning is an old way, strategic planning is a new one. Just remember the difference. In strategic planning, it's service based on customer needs, whereas in master planning, they prepare a service and then convince people to buy it. Okay. Strategic planning starts with external and internal analysis, SWOT analysis, whereas master planning starts with mission statements. They don't take into consideration the customer. They'll start what they want to do, they will produce it, and they will convince people to buy it. In strategic planning, planning is integral part of management, and master planning is not that important for them. Okay. Strategic planning, shorter time frames of 3 to 5, and to be modified as changes occur. As far as master planning is concerned, it has longer time frame. Many older healthcare organizations still operate like master planning. They build a service, then try to convince the patients to use it, right? Strategic planning actually opposes that, or sort of comes up with a different thing. They start with patient need. They'll analyze what does the patient need. They'll analyze the environment. They'll do SWOT analysis. They'll prepare a 3 to 5 year plan, and then they will see that everything is implemented, and that's how the world changes, right? So that's the difference between strategic planning and master planning. Now, leadership in quality, governing bodies, and closing. So see, here leadership in quality, senior support. Quality initiatives must be supported by senior leadership. That's clear. As far as communication is concerned, leaders must effectively communicate quality goals throughout the organization. That's the responsibility of the leaders. Commitment, to improvement, commitment to fostering ongoing quality enhancement is also responsibility of leadership. Okay. So in a way, like when senior support is missing, or if communication is vague, or if continuous improvement is just a slogan and there is no actionable thing, then no quality initiative can take place successfully. Remember that. Responsibilities of governing body. First thing is accountability. Remember, ultimate responsibility for safety and quality care lies with the governing body or the top leadership. This is one of the questions that you definitely may get. Not in an explicit way, but the concept. Remember, ultimate, the final responsibility for safety and quality in an organization lies with the governing body. Remember this particular thing. Governing body is supposed to allocate the resources. They are supposed to ensure sufficient support is there for QI. Okay, they will provide strategic approval. They will approve the quality plans and the budgets for it. That's their responsibility. They are supposed to be overseeing, supervising the quality initiatives. They are supposed to monitor. They are supposed to take feedbacks, regular sort of progress things. Okay, in a way, like, see, it's not like it's like the board doesn't run quality improvement. They own it. Okay, and you say, in case if your board doesn't ask you what are our serious safety events that are happening, or what are the recent safety events, I mean, like, if they don't ask you, like, did we actually hit the quality targets this time, the organization will not prioritize quality if they don't ask these questions. Okay, and in a way, like, remember, boards shape the culture from the top. We have discussed this earlier in the question answer session as well, right? Now, roles and responsibilities of quality leaders. So these are the responsibilities. Communicate in a way that inspires others to move the project forward. They involve others, allowing members of organization that will be impacted by change to be part of it, support successful change. For example, for any QI thing to be successfully implemented, you are supposed to have the end users. Okay, motivating. They allow employees to reach higher level of goal accomplishment. They should be rewarding. They should be promoting teamwork, right? So in a way, like, to say, quality leaders communicate the vision. They involve the frontline staff to get the solutions. They motivate, and they incentivize and reward the progress, and they also promote teamwork. Okay, so in a way, like, that concludes our today's session. And I know it was a little bit of hectic thing, but we are done with the session on healthcare leadership healthcare quality leadership. And now I am open for question answer sessions, if any.